MIT. He previously received an MD from Harvard Medical School, a PhD degree in physics from MIT, and he has co-founded 2 companies, authored over 250 academic papers, and is the inventor on 25 patents. He is Superman himself. Please welcome Professor Cohen.
Thank you very much for that introduction. Since maybe, actually the reason I think I'm here is that I made Jennifer's software full of my courses for a semester. Okay, great. Thank you. Maybe because of my medical background, I'd like to start off with a clinical case. But for reasons of privacy, I picked a case from 4 decades ago, and furthermore, I can tell you it's not actually a real patient. But it is a conglomeration of types of patients that I took care of at what was then the Peter Van Brigham Hospital, now the Women's Hospital. A very typical type of case that I took care of when I was an intern. So this patient's a 50-year-old male attorney. He suffered an acute myocardial infarction, was brought to the emergency room, and he got a intravenous drip of lidocaine, which is used to reduce irritability, electrical irritability of the heart to prevent development of lethal heart rhythm disturbances such as ventricular fibrillation. Had a special catheter put in, which is used as a very scientific way of monitoring cardiac function. This intern, RC, comes on duty Saturday morning, stays on duty through Monday night. That we used to be on call every other weekend, and the weekends we were on for about 70 hours. Patient had digitalis. It's a very old drug which is used to increase the force of contraction of the heart. His heart was damaged because he had myocardial infarction, heart attack. He also was given diuretics to reduce the amount of fluid in his body, which tends to accumulate when the heart is weakened. He started having premature ventricular beats, arrhythmias, serious arrhythmias. He was given a drug, quinidine, also a very old drug, which is used to suppress those extra beats, potentially life-threatening if they progress further. He did well, recovered uneventfully, went home. He had a 24-hour EKG monitor, a Holter monitor, to see whether he was having arrhythmias at home. The result was that he had a large number of extra beats, premature ventricular contractions. He was given more drugs to suppress those extra beats. And they had a repeat 24-hour electrocardiogram. Had now success, very few extra beats were present. He didn't have any angina, which is sort of the chest pain or chest discomfort associated with coronary artery disease. But he underwent a coronary angiogram to see if he had any narrowings of his coronary arteries. So he went to the cath lab to look for that. He had, they found blockages. He had coronary artery bypass graft surgery, once again successful. Oh well, before he had it, cardiologist told the patient the family should pray for a good outcome. He had the procedure, resumed his legal practice, and 3 months later he died in his sleep. And, oh yes, the family made a bequest to the hospital for research purposes. So this is a very typical patient, not a real patient, but a very typical patient. And the Peter Van Brigham and now the Brigham is considered one of the top hospitals in the world, particularly for cardiac areas on the U.S. News and World Report. It's usually 1 or 2 or something like that. I can tell you that it was the most scientific hospital based on clinical evidence and so forth. I think this just went out again. Okay, so I can tell tell you, virtually everything we did to that patient, based on what we thought was the best clinical practice and based evidence, virtually everything we did was either ineffective or may have harmed that patient. So let's go through it again. Intravenous lidocaine, subsequently shown no benefit. Swan-Ganz catheter, even though it's based on science, no benefit and increases the risk of complications. Being on duty for 70 hours, really bad. There have been good studies of functioning of sleep-deprived interns. If you, they would follow an intern. Chuck Seisler at the Brigham did this. You follow an intern over 24 hours as he gets sleep-deprived. You ask the intern, how are you doing? He says, just great. If you look at objective measures of performance, it looks like that. And so sleep-depriving physicians is a really bad idea from a patient care perspective. Digitalis is really not used anymore, not shown to provide benefit, only in rare cases. Quinidine, we'll see that use of antiarrhythmic drugs is generally a bad idea for ventricular arrhythmias. Quinidine is probably the worst, particularly in conjunction with digitalis, because it tends to displace digitalis from its binding sites and cause toxicity from the digitalis. I went home. I found it had a large number of extra beats on his ECG. More antiarrhythmic agents, also bad. And in fact, may have led to his demise. So they actually increased the risk of ventricular arrhythmias, of serious ventricular arrhythmias. Doing coronary angiography on asymptomatic patients, the interventions you do have not shown to provide any benefit. And you think that telling the family to pray for the patient would be fine. Actually, prospective clinical studies showing that if you tell a patient that people are praying for them, they actually have worse outcomes. And that was a very well documented clinical trial. I think that's the only thing we can really say is making it the best of the hospital. So here we were at the hospital, one of the best in the world, and virtually everything we did was either ineffective or had increased the risk of adverse outcomes. So how could that be? And it turns out many things are introduced into medicine based on science and clinical experience, and it turns out that it's just because biology is so complicated, healthcare is so complicated, there are unanticipated consequences. And things get introduced often for very narrow indications, but then because they make quote unquote so much sense, they're used very, very broadly. And they stay, and of course the practitioners who do those procedures want to continue doing them. The reimbursement, the hospitals like doing because they get reimbursed for them. And here's just another example. This is probably the oldest clinical procedure done, documented in each of the 1,000 BC, and continued as a mainstay of medical therapy through the end of the 19th century. So at least 3,000 years of being a mainstay of clinical practice. It's the reason we have a red stripe on barbershop holes. But there are actually extremely few conditions in which this is beneficial. Vanishingly small number of conditions where it's actually beneficial, and it accelerated the demise of many patients throughout history, including our first president, George Washington, who developed some pharyngitis, was bled 3.75 liters, so he was bled 75% of his blood volume, and as a result, he died. And actually, there was another physician in attendance. He wanted to do a tracheotomy, which actually would have may have solved his problem, but he wasn't allowed to do that because it was considered to be too risky a procedure, as opposed to bleeding him with 75% of his blood volume. So let me just give you one or two more examples. Percutaneous coronary intervention for stable coronary disease. So this is coronary disease, and you can see that as it progresses, the lumen gets occluded. So it makes eminent sense. You go in there, you put in a balloon, open it up, put in a stent, hold it in place. The patient's going to do better, right? So the first one was done in 1977 by Andreas Grunstig. I actually took care of the first patient in the U.S. who had this procedure done. It didn't go well. The addition of bare metal stents was introduced in 1986, drug-eluting stents in 1999. Now there are 1 million of these put in annually. In 2007, there was a study showing, and we're talking here about patients with stable coronary disease. Now, we're not talking about patients who are having an acute myocardial infarction, which is a different situation where you need to have an acute intervention. But these are patients who have stable disease. The CARD study showed that opening the vessels this way had no impact on outcomes such as mortality and recurrent myocardial infarction. So from 2007 to 2017, we continued doing it because we were told that it relieved symptoms. And then in 2017, another study showed no, it really doesn't work any better than optimal medical therapy. And there was an article in the Lancet editorial said, nail in the coffin for use of PCI to treat stable coronary disease. This is the cardiac arrhythmia suppression trial. I talked a little bit about this. It turns out suppressing extra beats with antiarrhythmic drugs, when it was tested, actually the patients who got the drugs, which were effective in suppressing those extra beats, had substantially higher mortality than patients who got a placebo. Not only did they have a higher mortality, specifically their arrhythmic mortality was higher. And here's another one, Canadian breast cancer screening study, 90,000 of a huge study, randomly assigned to 5 years of annual mammography or control. The endpoint was death from breast cancer, 25-year follow-up. Enormous study, tremendously long follow-up, found absolutely no benefit, either in terms of breast cancer mortality or in terms of total mortality. So a lot of things in medicine that make eminent sense when you actually test them. Some do, but you can't just because something makes a lot of sense and is obvious doesn't mean that it's actually it's going to be beneficial. And things persist in clinical practice for decades before it's realized the practice is not benefiting patients. So, scientific method was based on the work of Charles Pierce and Karl Popper, and basically, scientific method involves retrospective formation of hypotheses from past experience, but then, very importantly, you have to test it prospectively. In clinical medicine, the randomized prospective clinical trial is the gold standard for clinical hypothesis testing. So, the bottom line is the most obvious of untested conclusions are not necessarily true. And so, I think the biggest challenge in healthcare is making sure when we introduce a new technology, whether that's blockchain or something else, is that we need to prospectively test for the safety and efficacy of any new technology, even if we're 100% sure it's going to be helpful, because there are so many unintended consequences. And especially the ones that are obviously safe and effective are the ones that are in greatest need of being tested.